Good evening, everyone. Welcome to the session. I am Arpita from the IGCP group, and I will be moderating today's session. The topic that we are going to cover today is complex cataract cases, challenges and solution in surgical decision making. And yes, to address this topic, we have with us someone very eminent from the field of ophthalmology, none other than Dr. Kuresh P. Muscati, sir. It's an honor for us, sir, to have you again in our platform. To give you a short introduction, Sir has done MBBS, MS, DOMS, FCPS, FICS. He is Chief Cataract Services at Muscati Eye Clinic, Mumbai. So, sir, now the stage is to you. Over to you, sir.
Thank you. And I hope my audience consists of general doctors as well as young and old eye surgeons, because
Right, sir.
cataract surgery has changed so much in the last 30 or 40 years. When I was training, we did a lot of eye camps where we did cataract surgery. All we had to do was go and see. For example, what is a cataract first? Let us just see this. If you can see the picture here, this is a slit lamp view. That means it's seen like in a slit. And this area is normally clear. When it becomes opaque or cloudy, the lens of the eye, like the old camera lens, we call it a cataract. So in the old days, the whole cataract, this whole cataract would be removed. It would be plucked out either with a forceps by making a very large incision, 180-degree incision like this at the limbus. The whole cataract would be removed, either frozen and on a pencil called a cryo and plucked out, or it would be pulled out with a forceps. And then plus 10 glasses, thick, very thick glasses would be given. So it was a 5-minute procedure, and many times 3 to 5 stitches were taken. And so there was no the complexity in the case. Every case was handled the same way. All of them were given plus 10 glasses and plus 13 glasses for reading. So very thick glasses, and they had no choice. And from that time on, the IOL era came in, where intraocular lenses came in. And now the choices for the surgeon and the patient also widened. Unfortunately, now we have the internet era where the patients are challenging. If you can read the topic, challenges and solutions in surgical decision making, now I get sometimes patients who are challenging my decision. So I am making a surgical decision and they have Googled it. And they say, why this lens? Why not that lens? Why do you this way? Why not do it that way? So sometimes there can be too much information with information overload, what I would call. Let's take a few classical examples. In the space of half an hour, I cannot cover all the complex cases, but let's take a few common ones and see how we arrive at decision making. So let's start with children with cataract. Sometimes children are born with a cataract. It could be in one eye or both eyes. If it's one eye, it's unilateral. So always the issue is, when should I operate? If I operate, should I put in an IOL or not? And how to manage amblyopia or lazy eye, because the eye with the cataract is not been seeing for some time, so it tends to become lazy. Even if you remove the cataract, that is only half the battle. You have to manage the amblyopia or the lazy eye. You have to stimulate that eye. So let's start, before we go to more questions, let's start solving each one. So if it is a unilateral cataract, only one eye has a cataract, the earlier we operate, the better. We have operated even 6 weeks old children with a cataract, because if the cataract is fully mature, as you can see in the picture below of this child has a fully, you can see this white glow here as opposed to the black glow here. So it's a fully mature cataract. They're born with that. No light is going in to stimulate the retina. Unless I clear the visual pathway and allow light to go in, this eye, if I operate at 5 years of age, for 5 years that eye has been blocked. It's like putting a patch or a putty on top of one eye. So even if I remove that cataract, put in the world's best intraocular implant, that eye is not going to see, because it has not seen for 5 years. It is like tying one hand behind your back for 5 years, and then if I release that hand, I tell you to lift up some weight, With the other hand, you will lift 20 kilos. With this hand, you might not lift even 1 kilo because the muscles have all atrophied. So similarly here, the retina is not used to taking images from this eye. Even if clear images go at the age of 5 years, the brain has shut off the master switch. So if it's unilateral, we operate immediately. You can't put in a lens implant till the child is about 2.5 to 3 years of age. So if I operate at 6 weeks or 2 months of age, obviously I'm not going to put a lens implant. So what do? I put a contact lens on top of the cornea. And as the child's eye grows, we change the power of the contact lens. So you can keep on doing this till the child is about 3 years of age. And at that time, you can put what is called a secondary IOL implant. That means operate again and put an IOL. Why don't I put it at 6 weeks or 2 months of age? Because the eye grows so much in size that IOL will be either too big for the eye, or if I custom make it, it might become too small as the eye grows and fall away. Also, the power of the power required. How do I calculate? There is no correct decision on how to calculate the power at 2 months, because the power at 2 months is different from at 6 months and different from at 1 year. So even if I put a lens, I have to then give him glasses. I can't give glasses if it's one eye. So still I have to put a contact lens. So therefore, it's better not to put an IOL immediately, but to put a contact lens. Situation changes if it is bilateral. If both eyes are affected, the child is not going to become amblyopic or lazy, because both eyes, and when it's bilateral, is usually not full. So some light is going in. What we do is we put dilating drops like atropine or homatropine. So some light goes from the periphery to the retina, and we wait till the child is 3 years old and then operate. However, if the cataract is mature, even if it is bilateral, you have to behave like unilateral, operate as early as possible, put the child on contact lenses, keep calling the child every 2 months or 3 months, and change the power of contact lens by doing what is called a retinoscopy to find out what is the appropriate power. How do you calculate the IOL power? There is no 100% accurate way. One of the ways, even if you're doing it after the age of 3, is to simply remove the cataract. Then on the table itself, when the child is under anesthesia, you do a retinoscopy and find out what power of lens is required, and then put that appropriate powered IOL. So you have to keep a big stock of IOL and put the IOL there. But more important, as I said, in children is visual rehabilitation, prevention of amblyopia or lazy eye. So if it's a bilateral cataract and we operate it, you can even give spectacles, because both eyes spectacles the child will tolerate, even with those thick glasses which we used to give in adults. You can give contact lenses in both eyes. And if the child is above the age of 3 years, as I said, you can rehabilitate by putting in an intraocular lens implant. Let's move on to a second condition. Just like in a child, this exists from birth, but it manifests in later life. A condition of the cornea called Fuchs dystrophy. For that, let us see what the cornea is. The cornea is the front portion over here, like the glass in front of my watch. So this is called the cornea. The lens is somewhere over here. So this is the cornea on top. This is the iris, and the opening in the iris is called the pupil, and behind the pupil is the lens. Now this cornea is made up of multiple layers. The inner lining here is called the endothelium that you can see in this black and white picture. This inner lining the epithelium is like skin. It gets cast off and new epithelium grows all throughout life. But the endothelium, the child is born with a particular endothelium, and as the child grows, when the endothelial cells die, the other cells just expand in size and fill up the space, but they don't replenish. Now, if a child is born with poor endothelium, that condition is called Fuchs dystrophy, after the name of Dr. Fuchs, who discovered it. It's a dystrophy. So the endothelium is not healthy. So this inner lining is not healthy. So water from here, called the aqueous humor, which is in the anterior chamber, it goes into the cornea and balloons up or swells the cornea. So you can see here on the slit lamp in image, the inner lining of the cornea is diseased. It's not tight, and you can see some folds in the stroma. So water is going in, just like water goes in when there is, if you put water on a wooden table, sometimes the water goes in if it's plywood and lifts up and causes bubbles there. So that's because the endothelium, the inner lining, is not good. So here you can see these punched out holes. This is an instrument called a specular microscope by which we can actually see these inner lining. The inner lining cells should be like this, polygonal cells, well opposed. At some places there are gaps like vacuoles that you can see. So this is a loss of the endothelium cells. And the cell count in a child should be around 6,000. In an adult, it should be around 3,500. You can see in this patient with the specular microscope, the machine counts the count. This is per square millimeter. So cell count in this patient's eye is only 1897. And the thickness, the corneal thickness should be about 550 microns. The thicker the cornea means more water has gone in. So waterlogging occurs. So in this patient, the thickness is 662 microns, which is very thick. So if the cornea thickness is over 640 microns with a low endothelial count, the count is very low, of less than 1000 cells per square millimeter, then the decision making, if your patient comes with cataract and with Fuchs, should I tackle only the cataract? Should I tackle only the Fuchs by changing that inner lining, a condition called DSEC or DMEC, where we change only the inner lining? It's called posterior lamellar endothelial, deep decimate stripping endothelial keratoplasty, or DSEC. So should we do cataract combined with DSEC? Should we do only DSEC? Should we do only cataract? The decision making is made by using the instruments. This is an anterior segment OCT, which tells you how the endothelium is doing. This is the specular microscope, which tells you how the cell count is. And we have a pachymeter, which tells us the thickness of the cornea. So if the, as I said, if the cornea is very thick to start with a low endothelial count, and the cataract is significant, then if I just do a cataract surgery, while doing the cataract surgery, I'm going to destroy some more cells of the endothelium. So this cornea is going to get what is called bullous keratopathy later, or it's going to get decompensated. It's not going to remain clear. So I should combine the cataract surgery with the change in the endothelium. Nowadays, we don't do the full thickness, what is called penetrating keratoplasty. We do only the inner lining. So it will be cataract plus DSEC. If not, if the cornea, if the endothelium is not so bad, if the corneal thickness is not so bad, I will do only cataract surgery. I'll tell the patient that the recovery will be a little slow because your endothelium is diseased. And maybe 5 years, 10 years down the line, if the cornea decompensates, I might require to do a DSEC as a separate sitting. So so doing a combined surgery is quite stressful. Doing two separate surgeries would be easier, but provided the endothelium is not so bad. And what is the technique? Suppose I'm doing only the cataract. This is for all the cataract surgeons here. My surgical technique using phacoemulsification would be what is called a soft shell technique, which was invented by a Canadian, Gimbal. And we use copious amounts of viscoelastics to coat the inner lining to prevent further damage to this endothelium. And I would do a phaco chop technique and low flow irrigation. So I would keep the parameters very low. Otherwise, if the irrigation is very fast, it will damage more cells. Let's go to the third one. So we've talked about pediatric cataract. We've talked about cataract with Fuchs dystrophy and decision making there. There is a peculiar cataract called a posterior polar cataract. Posterior polar means it occurs only at the back of the lens, and it's like as if it's at one pole, only in the center. And you get this onion ring-like appearance. If you can see this picture over here, there is this onion ring-like appearance over here. The problem with this posterior capsular cataract or posterior polar cataract is there is a 25% chance of defective posterior capsule. So when I remove this cataract, if the capsule which is just behind this cataract is defective congenitally to start with, the vitreous may come out or the cataract might fall into the vitreous. So it's almost quarter of the cases. And 35% chance that if there is no defective posterior capsule, by my surgery itself, I might cause a rupture of the posterior capsule because it is extremely thin. So almost one third of the patients, I will have a complication. So we need to warn the patient of the complication. Ideally, posterior polar cataract should be done only by experienced eye surgeons. We don't do a hydro dissection. You can do a hydro delineation procedure where we don't dissect the whole cortex and epinucleus. We push the little bit of saline only to dissect out the nucleus. Don't rotate the nucleus. Do an oval capsular axis. And again, very low parameters in the phaco, low aspiration flow rate, low vacuum. Do a bimanual, use two hands for the irrigation aspiration. And we don't polish the capsule because the capsule is so thin. If you polish the capsule, it will break. So this is how you tackle this, and keep vitrectomy equipment ready, because if the nucleus drops in, or if the capsule ruptures and vitreous comes forward, you might have to do a vitrectomy. In that case, you should plan for you should keep a lens which is a three-piece lens so that you can put it in the sulcus rather than in the bag. Or you should be experienced in doing a scleral fixated lens where you don't need the bag itself. So as I said, it should be done by experienced people. Either keep a vitreoretinal surgeon at standby, or you should be an expert at tackling the complications which may occur. And almost one third of these patients will have some complications. Let's go to a commoner problem. In the elderly, as we grow older, our chances of glaucoma is where the pressure in the eye increases. So patient might come to you with a cataract, which is age related, and glaucoma, which is also age related. Normal pressure in the eye is about 20-21 millimeters of mercury. Suppose you get a patient with 40 millimeters of mercury pressure, glaucoma, and he's got a significant amount of cataract. Again, the problem like you had with Fuchs dystrophy. Remember, I told you you could do either a corneal or a cataract surgery or both. In this, you can either do only cataract surgery or a combined procedure, cataract with glaucoma or only glaucoma. Let us spend a minute or two to decide how I would arrive at a decision. So combined surgery where you do cataract with glaucoma, unlike when you're doing in a Fuchs the cataract with a DSEC, that is not so advantageous. Here combined surgery is advantageous because it's very convenient, it's lower cost, patient doesn't have to pay for two surgeries, quicker visual recovery because the pressure also comes down, cataract is also removed, the IOP remains under control, you can put the IOL of your choice. So ideally, if there is significant glaucoma, where the glaucoma is not under control with say one drop alone, and there is significant cataract, I would do a combined surgery. If the glaucoma is under good control, suppose just with one drop in the eye once a day or twice a day drops, his pressure remains 20-21. And if the optic nerve is not showing much damage, if the visual fields are normal, so glaucoma is under good control, but his cataract is advanced, then I may do only cataract surgery. If the angle of the eye is narrow, there are two types of angles, narrow and open angle. If the angle is narrow, the cataract is the one which is pushing the iris towards the angle and crowding the angle. So doing only cataract surgery will help because the cataract will no longer crowd the angle. So that's another indication to do only cataract surgery. So to repeat, normally I would do a combined surgery if the pressure is not under good control and there is advanced cataract. If the glaucoma is under good control or the angle is very narrow, then just doing a cataract surgery will help. Post-operatively, I tell the patient that you might require to put one or two drops in the eye for life for glaucoma control, which he will not mind because he was doing that earlier also. Suppose cataract is very early, then don't be tempted to do the cataract because you can do the cataract easily after 5 years or 10 years if it progresses. If the glaucoma is more of an issue, the nerve is showing signs of damage, the visual field is narrowing, it is very imperative to control the glaucoma well. So in such a case, I will do only glaucoma surgery and postpone the cataract surgery till maybe 4, 5 years, 10 years, who knows. Let's go to one more problem which we see even in metropolises like Mumbai. Sometimes patients, for various reasons, delay their surgery. They're afraid of surgery, or they've got a lot of other conditions like diabetes, hypertension, they've had bypass surgeries, or their general condition is not so good. So they avoid this, or economic condition is not good. So they postpone their surgeries till such time as the cataract is very hard. So a hard cataract is more difficult to do by phacoemulsification, simply because, yes, I can increase the phaco power. The more the phaco power I use, the endothelium, the inner lining of the cornea is very delicate, as I told you. The more the endothelial cells will be lost. So if I'm doing a phaco for a hard cataract, like you see in the top picture here, where this pupil is not well dilated, you can see this pearly white and little brownish tinge in the cataract. So that's a very hard cataract. So I will have to use very much of phaco power. So I'll have to minimize endothelial loss and protect at the same time the posterior capsule from rupture. Because the harder the cataract, the thinner the posterior capsule. So what are the strategies that we use? We use a capsular dye, because when I'm making the rhexis, rhexis is the opening in the anterior capsule. It tends to run away to the periphery. So I use a capsular dye which strengthens the rhexis, a dye called trypan blue, make a little larger rhexis so that I can go in easily with the phaco probe, do a very gentle hydrodissection, push some saline in. And here I use a very high vacuum because I want to hold the nucleus. I don't want it to go away from me. And in some of the modern phacos, we have something called the burst mode, where we get multiple very fast, the phaco tip vibrates very fast here and bursts the cataract. And use the viscoelastic devices, ocular viscoelastic devices, or OVD as we call. I keep pushing it in at regular intervals to coat the inner lining of the cornea. Some recent advances are in the traditional, we used to use the phaco, as you can see in the bottom. The phaco, which would make four the trenches, one trench vertical, one trench horizontal, or make it into a cross shape and then eat up the individual pieces. Now we can use something called a femto laser assisted cataract surgery, FLACS, or FLACS. Femto laser assisted cataract surgery. What does that do? The femto laser makes these cuts, no matter how hard the nucleus, it can easily cut through this with a femto laser. It's done in a different room from the operation theater. The femto laser makes the cuts. It can make 4 cuts or 8 cuts, and it can make a perfectly round capsular axis as well. Then I take the patient into my operating theater, and there I proceed with the phacoemulsification. So I have to use much less power. The other new technique, new advance, is the use of something called MyLoop, MILOOP. MyLoop is like a snare. It's a snare which, when it goes into the eye, it snares the cataract. When I just press a button, the cataract is broken by the wire which is inside. You can see the wire here in B, this small little round thing. It opens and expands when it goes in, and it goes around the cataract, and I can snip that with the wire. So the cataract is broken into 2 parts, then I can break it into 4 parts, and then I can use the phacoemulsification. So these are some of the recent advances for a hard cataract. Sometimes in elderly people, so age related, cataracts can come where the pupil just refuses to dilate. Now, to put my phaco probe in through the undilated pupil, it's fraught with danger because it's a blind phaco surgery. The causes are age related, a rigid pupil. You can get a condition called pseudo exfoliation. Patients who are on prostate medicine, like tamsulosin, they have what is called a floppy iris. The iris loses its texture and flops around and doesn't dilate. And sometimes if the patient has had old iritis, you can get posterior synechiae, or the pupil is stuck to the lens. So a lot of risks, because the iris might bleed when I'm operating on it. Iris might get damaged permanently. The iris might prolapse from the wound. In a floppy iris, it just comes out from the cataract wound. And if the pupil is small, I can't see everything. So I might leave some parts of the cataract behind. And again, inserting the IOL as a blind procedure through the pupil, I might have a problem with inserting that. So there are now many methods to manage this. One is use of pharma, that means use of special intraoperative injections of tropicacil or tropimide, which is done during the surgery, which can dilate the pupil. Copious uses of oculoviscoelastic devices such as methyl cellulose, the chondroitin sulfate, and sodium hyaluronate. These help because they are viscous, they help to spread the pupil up around. And then there are mechanical devices. All types of rings are available. I'll show you in the next slide. And iris hooks, just like fisherman's hooks, you can hook them so they pull the iris apart. Then there are surgical maneuvers like stretch pupilloplasty. I take two hooks and I stretch the pupil on both sides to sort of open it up. I can use an instrument called a repositor to break the synechia. It's called synecholysis. That doesn't work. I might have to cut the iris with the scissors. And while I'm operating, I use vertical chop in the phaco. So this is the small pupil management. You can see I'm stretching the pupil with forceps. I'm pulling it and pushing it in different, and you see the third picture here. After I've stretched it, the pupil expands quite nicely. This is a Russian author who made a Malyugin ring because his name is Boris Malyugin. It stretches the pupil after putting it into the eye through a small opening. I can put it, and I can put iris hooks like this. I'm putting an iris hook. It pulls the iris towards the limbus. So then I can pull it in 4 directions and I get quite a large area in which I can work. So these are some rings are now made in India also, like the B hex ring. The then coming to the next one is a subluxated lens or a dislocated lens. So the lens is not in its place. Somebody has boxed you and the lens has fallen or it has broken from the zonules. Zonules, it's like our lens is suspended in the eye through suspensory ligaments, just like a hammock is suspended from two trees. So if those suspensory ligaments are broken, which can happen in pseudo-exfoliation because the suspensory ligaments are weak, or in trauma, the lens is hanging partly in its correct place, partly going towards the retina. So that's called a subluxated lens. So there are several options available to treat this. You can remove the entire lens, including its capsule, which is called intracapsular cataract. This is what we used to do 40 years ago. Then you can implant an anterior chamber lens, or you can fix a posterior chamber lens by clipping it to the iris, or you can glue it to the sclera or suture it to the sclera. If the subluxation is not too much, I can put what is called an endocapsular tension ring or the CTR, capsular tension ring, it's known as, to stabilize the bag. These are some of the what the endocapsular ring. So it goes inside the bag and pulls the bag apart. So it stretches the bag so you can put the lens implant inside. And the last case that I will talk about, a previous corneal graft has been done. I have done a corneal graft, as you can see here. You can see this is the marking. This is the whole cornea is here. These dots are where the sutures were. And there's a very clear corneal graft on top. Inside is a pearly white cataract. The technique of doing a cataract surgery is same as in Fuchs dystrophy because you want to protect the endothelium of the cornea. So exactly the same technique, soft shell, phaco chop, and low flow irrigation. In conclusion, all cataract surgeries, even the normal ones, can develop complications. Surgeon has to be always alert and prepared. Some unique situations where complications are more likely I've discussed with you today in today's talk, along with how I plan prior to the surgery. I'll be extremely happy to answer questions. Thank you so much for your attention. Over to you, Arpita.
Yes, sir. Sir, thank you. Thank you so much for such an insightful presentation. And sir, definitely we have received some questions from our audience. Sir, the first question is, how do you approach IOL selection and fixation in patient with inadequate capsular support, especially in cases of traumatic cataracts?
So luckily I've answered that in the last question. the traumatic cataracts and patients with inadequate support is in, they're called subluxated lenses, and you can put a CTR or a capsular tension ring at that time. Or if you're well versed with there are techniques of fixing, removing the whole cataract and fixing the lens implant to the iris called iris fixated IOL, or you can fix it to the sclera. There are many techniques in that. One of them is called Yamane technique on the Japanese person who invented it. There is also the Agarwal technique of glued IOL. So there are many ways you can fix it, either in the anterior chamber or to the iris, or more commonly done to the sclera. Thank you.
Another question, sir. Hard cataract and mature cataract shall be taken for 6 directly or convert?
It depends on the skill of the operating surgeon. There is absolutely no harm in converting. Converting means you plan a phacoemulsification and it's not going well. You can convert to a manual small incision cataract surgery. Absolutely no harm. If you're confident, go ahead. If you're not confident, straight away, don't do phaco in such a case. Instead of that, go for an extracapsular cataract or a manual small incision cataract, which is the sutureless procedure. Idea is don't do any harm to the patient. Don't go with ego. Thank you.
That's a very practical advice, I would say. The next question is, which one is the best forceps for CCC?
It depends. I use a needle even now, bent cystotone bent 26 gauge needle for CCC, but you can use an Utrata forceps, and there are many variations of the Utrata forceps which have been made. One of them is Haldipurkar's forceps. Again, depending on the inventor, I have no financial interest, but whatever works well for you. Try a forceps. If you see someone using it and you are happy, you see it in a conference, purchase it. Try it first on animal eyes and practice it till you're perfect. If you don't like it, just because it worked in somebody's hands, it doesn't mean it will work in your hands. So try it on animal eyes. Don't risk a patient. iBank will also give you eyeballs on which you can try it. And then once you're conversant and you like that forceps, then use it for yourself. Thank you.
Right, sir. One last question is management of PCR.
So this, as I said, if it's a small piece, PCR is posterior capsular rent. If it's a small PCR, you can convert it into a posterior capsular rhexis, that means make a round surface. If vitreous has not been lost, you can still put a lens in the bag. If at all any vitreous has come out, then you must do an anterior core vitrectomy and remove all that. See that there's no vitreous left in the eye, and then I would put a 3-piece IOL in the sulcus. Thank you.
Thank you so much, sir, for answering all the queries. So with that, I would like to conclude the session for today. And thank you so much again for putting your effort and your time for such a wonderful session. Thank you, and thanks to all the participants for putting up your queries. This makes the session more interactive. So thank you once again, sir.
Thank you. Okay, bye.
Bye, sir. Take care.